I would like to welcome Libby Dodds-Ashley, another good friend from working together for a long time. Libby's a PharmD, associate professor in the Division of Infectious Diseases at Duke University. She is going to talk to us about antifungal stewardship. Libby's interest is it's not exclusively antifungals, but she has written extensively about this, and really pleased to have her here. She's quite experienced and looking forward to what she has to say. Thank you for being with us, Libby.
Great, thank you. Well, thank you for that nice introduction. I'm excited to be here and see you all virtually. Sorry we can't be in person. And I hope to share some exciting work that I want to right out of the gate acknowledge my colleagues, Russ Lewis and Melissa Johnson, for their very hard work on this effort. We have all been working in the area of antifungals for most of our careers, and especially Melissa and I have done a lot of work on antifungal and antimicrobial stewardship in the recent past, and this is our attempt to merge those two worlds. So in order to really cover what's new and some current gaps, I wanted to take a moment to go back and talk a little bit about antimicrobial stewardship, which I think is pretty widely known as a practice, but I did want to spend some time on the frameworks that we build a lot of these practices on. And it has to do with a set of factors we have come to call the core elements. These were first released by the US CDC, and you can see the current core elements from the US CDC on the right half of your screen. And they were followed by an international consensus document more recently that was published in 2019. It was the result of a modified Delphi process from several different constituents that has largely been adopted now by the World Health Organization to underpin some of their antimicrobial stewardship work that they're doing. These core elements are important, and some of them might seem just accepted practices, but I'll just quickly go through them, and then we'll talk about how we pivoted and made these apply to antifungal stewardship. Key to all of this, I'm not going to talk much more about this today, is having support from senior hospital leadership for your stewardship activities. There needs to be accountability for who's going to be responsible for stewardship. Even though everyone's involved, there does need to be sort of a clear leadership structure for this. You need expertise in managing the infections and also in the drugs that are involved in treating these infections, be it antibacterials, antifungals, and we'll obviously pivot more towards antifungals in just a minute. There needs to be great education and not just mandates. We need to have actions, and we'll talk about those in general and related to antifungal stewardship, as well as monitoring and surveillance of your work, and then reporting and feedback back to frontline prescribers and others. And so with the release of the US CDC Core Elements, just to show you what having these guiding principles can do, the CDC has been able to track through annual hospital surveys that when these were first released, less than half of US hospitals complied with all 7 of the core elements. And these are for traditional ASP programs, and I'll show you in a minute how many of those may or may not include antifungal stewardship at baseline. But as you can see, with time and with attention, and a few requirements related to CMS, but not as many as you might have thought. They've actually gotten to well over 90% adherence with all 7 core elements with the over 4,000 hospitals in the United States today. So just having these out there and then trying to monitor them with time can really move the needle in terms of having these elements that we consider so essential to using antibiotics appropriately and causing minimal harm and preserving them for the future has really had great success. So that leads us to ask, I think, and I will shame myself, we are guilty here. When I was the pharmacist lead for the Duke stewardship team for many years, we often left antifungals for the last area on our list. And there was a group through the Shea Research Network that in 2018 actually conducted a survey of the members of the research network facilities. So remember, this is not all US hospitals, much smaller sample size, only 111 hospitals surveyed. A little under half of them responded to see how often their ASP, which at that point was required to be in place, actually included antifungal work. Now, I think surprisingly, but again, this is a very select survey population, 96% of them actually included antifungal stewardship as part of the routine work of their stewardship team, but not all the core elements were there when it came to the antifungal drug use. So we look at our 2 key actions, either being prospective audit and feedback to prescribers in real time or having some guidelines for treating common fungal diseases. Those occurred in almost 3/4 and just about half respectively. Rapid laboratory testing was available in 71% of hospitals, but this was much more variable when you looked at practices such as antifungal susceptibility testing available locally and universally for bloodstream isolates, just as an example. Also, mechanisms to perform surveillance of antifungal drug use, so measuring the antifungal drugs they use, only in 64% of hospitals at this time. Remember, this was just conducted in 2018. And then only about a third of them report that antifungal drug use into the CDC through the National Healthcare Safety Network. And we're going to talk about that a little bit more, just to give you some ideas of antifungal tools that are out there for stewards to help implement antifungal stewardship practices. So knowing that we had come so far in antimicrobial stewardship and knowing that we had big strides to take in antifungal stewardship, we worked with the MSG to develop the core elements of antifungal stewardship. And this was published in August of 2020. Melissa Johnson is the first author on the paper, and it's in a supplement to JID. I will say that this graphic does not appear in that publication. That is from a publication just last year that came out from Payal Patel that talked about some additional challenges of antifungal stewardship in immunocompromised populations. So I thought they did a great job with this graphic, so I decided to use it today. And we were very easily, through a lot of discussion and hard thought, able to apply each of the core elements to specific examples of how we could optimize antifungal use in our hospitalized patients today. So using the same principles of the international core elements that were developed through that consensus process, we pivoted and released these antifungal stewardship core elements, which really can guide ways to have a robust antifungal stewardship program. We have a brief time today, so what I want to do is actually highlight many of the questions that I get from people about having antifungal stewardship programs. And in order to do that, I think it's important that we set the stage about what we mean for antifungal stewardship. I know there's a lot of colleagues on here who are very involved in drug development and designing studies for drug approvals and optimizing and defining patient populations that will most benefit from antifungal drug therapies. But the reality is, the group of people on this call are not the primary users of antifungal drugs in US hospitals today, and those need to be the targets for the stewardship program. Just as perspective, I currently work in a network of community hospitals, and so I took the liberty of using some of our data. And when we look at all of the admissions in our 26 community hospitals, 56% of them will get an antibacterial drug during their hospital admission, and that's a lot. And you can see how that's a big target for traditional antimicrobial stewardship programs. When we pivot that and look at those same admissions and the percent that will receive a systemic antifungal therapy, it drops to only 3%, which may not seem like a lot. However, you need to think about this. Our hospitals in our network, our average bed size of 150, we go down to 20, we go up to a little over 600. But in that hospital sample, we still give more than 7,200 patients just last year alone a systemic antifungal drug. That is a lot of patients. And on average per hospital, it's 277 admissions a year, almost an admission a day, and over 1,300 days of antimicrobial therapy, antifungal therapy that are given to our hospitalized patients in the community setting. And we'll talk about what resources are available to them, but we need to think about antifungal stewardship across the board. There is a lot of antifungals use in areas that are not seen by ID practitioners, that are done in community hospitals or in areas of academic medical centers that are not heavily presenced by infectious disease specialists. So now let's pivot with that bit of perspective and think about some questions that have come up and ways to frame your program. And I think the one I most commonly get from people and colleagues is, do I need to have a standalone antifungal stewardship program versus integrating antifungal stewardship into existing stewardship practices? And within our guidance document that we published, we had a few recommendations. And if you haven't had a chance to review that article yet, this is the framework we use. We go through each of the core elements and then under each have key recommendations for practice related to antifungal stewardship. Our best guidance is, when possible, to incorporate and leverage the expertise of the local stewards with the expertise of your mycologists and the ID physicians who specialize in treating patients with fungal disease. So many stewardship programs will not have that antifungal or fungal disease management expertise embedded within them. And so it's a great opportunity to leverage those different areas of specialty in order to optimize various ways to optimize drug use. And I'll show you some examples of that as we go through this. But there is no need to reinvent the wheel when it comes to ways to fine tune and optimize therapy. Also, we don't want to be bombarding the primary teams in care of these patients with multiple different groups contacting them. So here's your call about your vancomycin, and here's your call about your voriconazole, as an example. So our recommendation is, whenever possible, to try to integrate these activities. The stewards, they've come a lot in the last few decades and have great tools available and often know how to leverage different systems within the facility, including the electronic health record, to help promote the right way to use antifungal drugs in your patients and move forward from there. So not a one-size-fits-all answer, though. And I will say that if you're a stewardship team and you do not have antifungal expertise at the table, you need to get it there. And I will go back to something I said a long time ago. I think we sometimes think in a very siloed fashion around what that means. Does that mean that you need your group that has expertise in treating fungal infections at your third Tuesday of the month stewardship meeting all the time? The answer is you might not. You might need to go to those groups. You might need to go to the hematology oncology group as a stewardship representative and not think of this traditionally as the stewardship team meets when everyone who's on the stewardship committee is at the same table. What it means is we need to all leverage this together. And so it might mean putting a stewardship representative on an existing committee that's thinking about the care, management, prevention, and treatment of fungal diseases in these high-risk patient populations. So it's very important to think a little bit differently in what it is to meet as a stewardship team. There might be multiple different sub-teams of your stewardship team that make it successful at a large academic medical center. A small community hospital, it might be the people you can get together and then bringing in outside expertise that we'll bring up in just a minute. In our guidance document, we also heavily endorse the fact that whenever it is possible, infectious disease consultation should be performed for some key fungal diagnoses. But the reality is, and we see this all the time in the DASON network where we do stewardship today, 63% of Americans live in an area with no ID specialist access. We see this a lot within DASON itself. 30% of our hospitals do not have the ability for an ID consult on site at the hospital. And this does not mean that we should just abandon the need for this specialized expertise. There are tremendous models. I don't have time to review them all today, but through remote consultation, through tele-ID consults, through tele-stewardship expertise, you can actually bring in very, very talented and specialized infectious disease specialists for treating fungal diseases from all over the country and sometimes the world to help guide these practices. And there are new models emerging that include compensation for this. And hospitals are getting more creative in how they bring the experts locally. Perhaps a positive benefit of the pandemic and all the telemedicine we've had to learn and pivot to so quickly. So there needs to be that specialist access. There needs to be creative ways to get it to all patients, and it needs to be done within the resources that are available. And that's one of going to be our ongoing questions, is how do we adequately resource stewardship teams to do the antifungal stewardship that is so badly needed today? Another question we get a lot is, what laboratory testing do we need to optimize our antifungal stewardship program? And we, in the article, review several of the available technologies out there and how they can be implemented in various settings. But I just wanted to raise a few items of interest that we've come across, especially in our community hospitals, but we also see sometimes even in large academic medical centers. Just because the technology is there, bringing it in does not mean it will solve a problem. And this is a great way where the stewardship program can work with the microbiology laboratory to optimize both avenues, workflows on the micro side, as well as optimizing treatment decisions on the patient care side. Some key considerations, and I think Melissa's on the line today. I know we've both run into this in our community hospitals, where we advocate heavily for having susceptibility testing available for blood isolates of Candida, for example. And we have several hospitals that would check that box as yes. And then when we talked to them, we found out that it was a send out that was taking 7 or 8 days to come back. Well, that was a large expense for the hospital, proportionate to what they were, receiving in reimbursements. And also, it wasn't giving us any meaningful data to help drive patient care. So you really need to go through a checklist of key elements around laboratory testing to be sure it's helpful. Some of the other things to consider after turnaround time are, do you have the local capacity for testing? We see microbiology laboratories all the time that have great diagnostics on the shelf, but only have a few people trained on them that don't have the time to run all the tests with everything else they have to do in the day. And so the start of these rapid diagnostics is delayed by hours, essentially losing some of the utility and tying up a lot of resource and the capital to buy those systems. You also need to make sure that the frontline decision makers are really receptive to the tests that you're bringing in. And I think this is so important. Be sure that they're at the table when you're designing these algorithms and how you're going to deploy this testing, because it may not matter that you have a great new test. It may not be actually something that they're willing to change practice on due to other things that might require some education to reverse or change prescribing practices. You can see some of the other checklist items here. You also want to think about other local practices that could interfere with the testing. There's a pharmacy list served for stewards, and actually just yesterday there were questions out there about some hospitals that were struggling with beta-D-glucan testing in their ICUs, and it was coming up universally positive, and they didn't know how to address that with providers because it was actually leading to an increase in antifungal drug use in that particular ICU setting. So always things to think about. What are the other things happening at your hospital that might make the testing not as useful as it has been in published studies? Now, I do want to bring up one interesting element around laboratory testing as it relates to antifungal stewardship, and I'll keep this brief, but when you might be at an institution where you are very interested in bringing in a certain technology around rapid identification or rapid susceptibility testing for bacteria, but it might be hard to cost justify, even if you can break down the silos between laboratory and pharmacy and even on to patient-centered outcomes like length of stay. There's actually evidence out there that in some cases, because of the higher cost of some of the antifungal drugs, they alone cannot justify those technology platforms. But if it's a platform that tests for multiple bacteria and fungal pathogens, for example, you can sometimes cost share, and bringing in the antifungal stewardship element can tip that over. There's a few great examples of that out there that we can share if you're interested. Now, what about actions? That is core element number 5 in most of the rubrics. And are there best antifungal stewardship practices to adopt? I think that hands down, when you look at invasive candidemia, the bundle approach that has a set of metrics that are used and are protocolized whenever a patient has a candidemia identified have been shown to improve initially, arguably, process measures, I will admit, but you can certainly improve things that are tied to better outcomes for patients. And at the end of the talk, I'll show you some newer data that are emerging that even suggest mortality is a benefit in a recent trial that was published. Also, there are many daily stewardship interventions that are going on, primarily focused on antibacterials. I think one of the ones that's getting the most attention right now are handshake stewardship rounds. These are quick verbal communications between the primary team and stewards, be it pharmacists or physicians who have reviewed the patient, where you can quickly discuss the plans for antibiotic and antifungal care. Because this is already an existing structure, this is a great way to put additional elements of antifungal stewardship. And this is a great way that with backup and support from the experts in treating fungal disease at your facility, be it on-site or remote, you can also expand antifungal stewardship in that existing set of resources without being a lot of extra additional resource that you need to devote. Now, I could talk literally all day about antifungal stewardship interventions, but as we get close to the end of our time, I thought I would just highlight that Russ, Melissa, and I, along with the MSG leadership and others, had categorized these, and this is where we spent a lot of work into having the elements that we thought were essential stewardship interventions to have a successful antifungal stewardship program, having achievable and then aspirational antifungal stewardship activities and goals. And I encourage you to look through these and reach out if we can answer any questions about or clarify any of these any further. But the easiest and most essential are integrating antifungal drug use into the basic components of your existing antimicrobial stewardship program if it's not already there. And then looking to grow and expand that to have additional diagnostics to put better information in the hands of clinicians so they can optimize care of patients quickly, to get them on antifungal drugs when they need them and get them off antifungal drugs when they don't, so we can preserve them for future patients. Now, one of the core elements I discussed was measurement. And so I think this is important to spend just a few moments on. And one question we get are, what should we measure with our program once we incorporate antifungals into our antimicrobial stewardship program? And I admit many of these are aspirational, but I did want to share some of the most recent data on the effects of antifungal stewardship programs on actual patient outcomes. Now, the first and the most commonly cited is not a patient outcome, it's decreased antifungal drug use. And I will completely admit that this alone will probably not motivate many programs to tackle antifungal stewardship with the many complexities that go into managing these patients. However, we now have data from the recently published COMIC trial that when you implement a candidemia bundle, you actually can have improved mortality. Now, I will admit this is a single study. With many of these, as with many, the sample size is low, but the fact that by optimizing the process of treating patients with candidemia actually showed a difference in mortality and not just on measures like the proportion of patients with an eye exam is significant to me. And so I eagerly follow it for a larger sample size to see if this is confirmed. There have also been just last year a publication that showed that antifungal stewardship efforts to get patients off of antifungal drugs actually decreased recurrence with resistant disease. And in a small study of neonatal patients, there was actually has been shown that with a very robust antifungal stewardship program that had about a complement of about 10 different interventions all intertwined, that might sound a little more complicated than it actually was, but it was a very comprehensive program that actually decreased resistance when tracking colonization in their neonates in their neonatal unit. So these are all reasons that we really should promote stewardship. So by improving the appropriate and decreasing the unnecessary antifungal use in our hospitals, we can really preserve these antifungal drugs for additional patients. And with these new drugs that we just heard about that are coming, we can have hope that we will be able to use them for now and many years to come once we get them available, by making sure we right size their use in patients who need them and minimizing it in those who don't. And then one last question is about antifungal drug use and how do I compare? So if I can measure my antifungal drug use, and remember, not all hospitals, even in that SHE network survey, were able to do this, but if you can measure your antifungal drug use, can I benchmark it? And the quick answer is yes. And now in the United States, we have the NHSN antimicrobial use option, which is risk adjusted at the facility level for targeted unit types and does include antifungal drug metrics. Their primary metric they use is a ratio. They call it the SAR, the Standard Antibiotic Administration Ratio. And they have developed this for antifungal drugs predominantly used for candidiasis only. So you will not see comparators there, for example, for voriconazole or posaconazole, but you will for others. And it is a start and a way to look at risk-adjusted antifungal drug use, again, for the targeted units. This is also a topic we could talk for hours on and are happy to answer any questions afterwards about the SAR as it relates to antifungal drug use. So I hope I've quickly shown you some of the data we have for antifungal stewardship, the progress we're making towards having this a more comprehensive component of antimicrobial stewardship programs, at least here in the US. But we have many remaining questions, too many to list on one slide. But I think that we still need to carefully think through and advocate for the resources that are needed in a facility related to their antifungal drug use to make sure that it is right-sized. We still struggle on the antibacterial side, but I think antifungal drugs need to be included in that equation and part of that calculation. We also need to know a lot more on which of the antibacterial interventions for stewardship apply best over to antifungal stewardship. What are our optimal outcomes to track? What should we be measuring? Will the findings of some of these admittedly small experiences that I've just shared with you persist in larger assessments of the stewardship efforts? And then once we determine best practices, what is the best way to educate our frontline providers about this in the midst of all the other information they're having to process and assess for the very complicated patients that are at highest risk for fungal infections? So with that, I want to say thank you, and I think I've left a little time for questions.
Thank you, Libby. That was comprehensive, and you covered a lot of territory in a short period of time. There are 3 or 4 questions I'd like to convey to you. The first is from Don Silla, and we want to know if antimicrobial antifungal trends have been impacted by COVID. We certainly have seen an explosion of use of meropenem, and so the question is, has that really followed along with the antifungals as well?
Yeah, Excellent question. We've actually been tracking this quite closely. From the antibacterial side, early in, March of 2020, we did see broad spectrum antibacterial drug use. And then by the end of 2021, it was still increased, but it really shifted over to a more community-acquired pneumonia. So a lot of ceftriaxone. And when you talk to the CDC, they're seeing the same trends. A lot of ceftriaxone use in these patients is what we've primarily shifted to. We have seen waves in antifungal drug use. We track it compared to releases and announcements about experiences out there for with aspergillosis. We've had a few regional cases here of mucormycosis. There's actually a prominent physician who was infected with COVID and ended up developing rhinocerebral mucor that got a lot of attention and actually led to a lot of antifungal therapy empirically as a result. So we are seeing trends like that. We are actually in the process of fully teasing out which of those patients are COVID. We've developed some denominators for that, but yes, certainly COVID is impacting this across the board. And we are seeing in our patients, we're putting some into the database, some cases of candidemia in patients, especially those when we started using high-dose steroids at some of our community hospitals. So definitely have seen impacts of COVID.
Right. John Badley asked the question. It's a good one because we seem to be seeing this, but how are you addressing diagnostic stewardship? And, for example, regulation of diagnostic tests, and they, like others, are seeing broad and maybe inappropriate use of T2 Candida, the galactomannan, the beta-D-glucan. Those are the three that would kind of come to mind. There are others as well. But are y'all keeping track of that? And what are you doing? And what trends have you seen, if you are, and what are you doing about it?
Yeah, diagnostic stewardship is very important. And we see a lot of misuse of diagnostic tests. People may come from an institution where they trained and had access to galactomannan. And so we'll come into a facility and say, I need to have galactomannan here. And they don't realize that they don't even have, more than a handful of aspergillosis cases in a year. So it's not really an appropriate use of the test, or they aren't willing to respond to the test. And so we do see some interesting trends. They tend to be very hospital specific. So what we do is go in and assess the use of a diagnostic and then show them, this percentage of time is how often you appropriately respond per your own institutional protocol to the test that you've ordered. I'll tell you, I don't think it's much different than when we first got antifungal drug concentration monitoring here at Duke. And I used to make the Duke fellows, when they wanted a voriconazole concentration, and it was going to cost hundreds of dollars, and we had to conserve that resource with the lab. I used to make the fellows write on a piece of paper and put it in an envelope and say, what are you going to do when that concentration comes back? And I think that's the hardest thing, is getting the data and then making sure we're actually using it to change patient care. And that's where we don't see that happening a lot. And then there are lots of other examples, like the pharmacy listserv I mentioned, where there's an ICU where there's a lot of beta-glucan being ordered, nearly essentially all positive, and they need to get to the bottom of why that is, because it's actually driving up the antifungal use and not decreasing it as the intent is.
Well, we have time for one more question. Louise Ostrowski-Zeitner said, can you provide some practical advice on how to break up the silo mentality that often pits the three entities, that is pharmacy, lab, and clinicians, that are all looking for better outcomes, but oftentimes kind of fighting against one another? I don't know if you encountered that there, if you all function as one unit, or if it, if you tend to...
I think that's one of the key reasons that leadership support is so important. And I will say, I came across a very creative model when I was at the University of Rochester that I brought to other places with me. The leadership there was, when they wanted to save money, they just wanted to save money. And so they came to us with a proposal that said, if two departments work together, you both get to credit the savings. And so I've gone to leadership and said that, when there is a test that we want to bring in a community hospital, and it's going to cost the lab a little bit, get patients out the door faster, and save pharmacy a little bit, we can sometimes come together and go to leadership and say, look, we want to do this together, but the accounting is what's in the way. And when you come with potential ways to put more patients in bed or save money on the pharmacy side, usually people will listen to you. So I think it's sometimes us breaking down the silos from the bottom up instead of waiting for the top down changes. Because in my experience, when you go and say, well, we have a better way to do this and it's going to increase revenue and it's going to save this person a little bit of money, but this person's got to spend a little bit. Will you let us all be creative? usually people will listen to you, but they might not come to you and ask you to do it that way. So you kind of have to, knock on the door and say, listen, we have an idea and let us in. We want to take better care. And usually you have success there.
Yeah, I mean, I think a good example is when you bring in a test that might lead to earlier discharges. The lab doesn't receive credit for that. They just see it as a cost.
Right.
Anyway, Libby, thank you again. That was terrific.
Thank you for having me.
Thanks for that. Oh, it's our pleasure. Thank you for being here.